dziewczyna to utknęła w ogóle gdzieś tam na lotnisku, nie wraca, także chyba i
Dobrze, ja tak tylko pytam, bo ja rzadko mam zajęcia. Jesteśmy na tym
Tak.
kanale, oni też to wszystko widzą, o czym rozmawiamy, tylko że większość z nich nie rozumie tego, o czym mówimy.
Ale są też osoby, które mówią po polsku.
To dobrze, to będzie mi łatwiej w razie
jak
czego.
co właśnie w razie
No.
co, tak. To
Aniu,
bardzo
ja zaraz się tam będę włączał do
Dobra.
tego wykładu. Dziękuję za
Bardzo.
zapowiedź.
Dzięki, cześć, powodzenia.
Typnik. I would like to welcome all English-speaking students. Today I will present the topic, the application of various devices and techniques used in the treatment of different diseases in nephrology. My name is Sławomir Mozul. I am a nephrologist and I work in the Department of Nephrology, the Medical University of Lublin. Procedures involving the use of extracorporeal machines will include hemodialysis, peritoneal dialysis, isolated ultrafiltration, hemofiltration, hemodiafiltration, plasmapheresis. All of these procedures are performed in our hospital, and some of them you have already seen during your nephrology classes. So the question is, what we use them for? These techniques developed after the Second World War in the 20th century. Before that, they weren't available, and even the wealthiest individuals often died from conditions that today can be treated. Currently, we have many different methods that allow for additional therapy, life prolongation, or even complete recovery. These techniques are now available worldwide. And These techniques are used as renal replacement therapy in acute kidney renal failure, in chronic renal failure, in poisoning by various substances, in poisoning by methanol, ethanol, glycol, paracetamol, for removal of unwanted blood components in severe heart failure and in severe liver failure. We'll begin with renal replacement therapy, which is generally divided into main branches: dialysis therapy and kidney transplantation. Dialysis is used in both acute and chronic kidney failure. These are life-saving procedures. Kidney transplantation, on the other hand, is performed only in cases of end-stage chronic kidney disease. Dialysis is further divided into two types: hemodialysis, which is the older method, and peritoneal dialysis. Probably you have already seen patients treated with two methods in our department. On this chart, we can see that the 5-year survival rate of patients treated with a kidney transplantation is the highest, around 80%, in contrast for both hemodialysis and the peritoneal dialysis. The survival rate is about half of that, falling below 40%. On this slide, we can see that the current 5-year survival rates after kidney transplantation are even better. For example, for living donors, the survival rate is around 90% now, while for deceased donors exceeds 80%. So the question is, why aren't all patients treated with a kidney transplant? For several reasons. Unfortunately, not everyone is a suitable candidate for transplantation. Some patients don't qualify due to comorbidities. For example, cancers, severe cardiovascular diseases, active infections, advanced atherosclerosis, or simply advanced age. But however, these patients still require renal replacement therapy, and for them, the only option is long-term treatment within a chronic dialysis program. What are commonly accepted criteria for initiating patients for dialysis? Significant metabolic acidosis, severe persistent hyperkalemia, hypermagnesemia, intoxications by methanol, ethylene glycol, lithium, paracetamol, and some other drugs, overload hypervolemia, not managed by other means despite diuretic therapy, especially pulmonary edema, uremia, especially severe, based on clinical presentation, not only laboratory values. Uremic pericarditis is an absolute indication for dialysis. In chronic renal failure, the fifth stage of chronic kidney disease, dialysis serves as a bridge to renal transplantation or as a permanent treatment when the patient is not a transplant candidate. Let's begin with hemodialysis. What is needed to perform this kind of treatment? We need dialysis center. In some countries, the patients might be dialysed at home, not in Poland. Staff, nurses, doctors, technicians. Patients qualified for hemodialysis in appropriate good condition with vascular access for hemodialysis, artificial kidney, dialysis fluid, specially prepared made of pure water, electrolyte concentrate, natrium bicarbonate, other dialyzers, needles, drains, and more. In this photo, you can see an artificial kidney. This one was manufactured by Fresenius. There are many manufacturers of artificial kidneys worldwide. The process of hemodialysis takes place in dialyzer. The entire hemodialysis process takes place inside the dialyzer. We can see it in these photos. It has a form of closed cylindrical cartridge. Maybe I will change something else. Cylindrical cartridge. Inside this cartridge, there is a semi-permeable membrane that divides the space into two compartments: an inner compartment through which the blood flows, and an outer compartment through which the dialysis fluid circulates. From the cartridge, separate lines lead out for the blood and for the dialysis fluid. In this picture, you can see a schematic of a hemodialysis circuit. Chronic hemodialysis is usually done 3 times a week for about 4 hours for each treatment, during which the patient's blood is drawn out through a tube at a rate of about 300 milliliters per minute. The tube is connected to a needle inserted in the dialysis fistula or graft, or connected to one part of a dialysis catheter without needles. The blood is then pumped through the dialyzer, and then the blood is pumped back into the patient bloodstream through another tube connected to a second needle port. Blood flows through the dialyzer multiple times during hemodialysis. At the same time, the dialysis fluid, yellow color, flows through the dialyzer at a speed greater than the blood flow, about 500 meters per minute, for 4-hour dialysis session. So 120 liters of dialysis fluid are needed to perform one hemodialysis for one patient. What can we achieve with hemodialysis? As you remember, our own kidneys have many functions. Hormonal function, for example, erythropoietin production, active vitamin D production, blood pressure control, removal of metabolic products, regulation of acid-base balance. But hemodialysis allows only 3 of them, only 3. Removing waste products which cannot be removed by sick kidneys, urea, creatinine, uric acid, potassium, magnesium, excessive sodium, removing excess water from the patient, and correct metabolic acidosis by natrium bicarbonate administration. So there are only 3 functions. Now about principle of hemodialysis. On this slide, we can see diagrams illustrating diffusion and ultrafiltration. 2 solutions with different compositions are separated by a semi-permeable membrane. This membrane contains pores through which water and small dissolved molecules, smaller than the pore size, can pass. The process continues until the concentration of these molecules equalize on both sides of the semi-permeable membrane. On the other hand, diffusion of bicarbonate is also used to treat metabolic acidosis. It occurs across the semi-permeable membrane from the dialysis fluid into the blood, because the dialysis fluid contains a high concentration of bicarbonate, while the patient's blood contains a low concentration. And here in this small picture, you can see a schematic of fluid removal excess water, called ultrafiltration. And this process is achieved by altering the hydrostatic pressure of the dialysis compartment, causing free water and some dissolved solutes to move across the membrane along a created pressure gradient. In patients where the blood contains high concentrations of urea, creatinine, and other substances that are present only in a very low concentrations in the dialysis fluid. Because of this difference, these molecules diffuse from the blood into this dialysis fluid, and their levels in the blood decrease during hemodialysis. Bicarbonate diffuses in the opposite direction to metabolic waste products because its concentration in the patient's blood is low. But the formed elements like cells of the blood and plasma proteins are too large to pass through the pores of cerebrospinal membrane. Important information that blood and dialysing fluid in the dialyzer flow in the opposite directions. And in this downline picture, you can see a schematic of cerebrospinal membrane with pores. You can see cells which are too big, too large to go through pores of cerebrospinal membrane. During hemodialysis, various adverse events and complications may occur. For example, side effects caused by removing too much fluid or removing fluid too rapidly include low blood pressure, fatigue, chest pain, leg cramps, nausea, headaches. These effects can be avoided or the severity lessened by limiting fluid intake between treatments or increasing the dose of dialysis. Patients undergoing hemodialysis may expose the circulatory system to microbes, which might be the cause of sepsis, endocarditis, bleeding, because heparin is the most commonly used anticoagulant in hemodialysis. But sometimes in a patient at high risk of bleeding, dialysis can be done without anticoagulation. And first-use syndrome, it is rare, but a severe anaphylactic reaction to the artificial kidney. And long-term complications include amyloidosis, neuropathy, heart disease, and more. During hemodialysis, we need to deliver the patient's blood to dialyzer, and there are several methods to achieve this. In hemodialysis, two primary methods are used to gain access to the blood: an intravenous catheter and an intravenous fistula. The type of access is influenced by factors such as the expected time course of a patient's renal failure and the condition of the patient vasculature. The creation of all these two major types of vascular accesses requires surgery. Catheter access. So we start from catheters. Sometimes is called CVC, central venous catheter, consists of a plastic catheter with two lumens, or sometimes very occasionally for two separate catheters, which is inserted into a large vein, especially vena cava, via the internal jugular vein or the femoral vein to allow large flows of blood. Catheters are usually found in two general varieties: tunneled and not tunneled. Not tunneled catheter access is for short-term access. For example, to about 10 days, sometimes 30 days. But very often just for one dialysis session. Catheter access is usually used for rapid access for immediate dialysis. But tunnel catheter access involves a longer catheter, much longer, which is tunneled under the skin from the point of insertion in the vein to an exit site some distance away. It is usually placed in the internal jugular vein in the neck, and the exit site is usually on the chest wall. So we have the tunnel under the skin, and the tunnel acts as a barrier to inviting microbes. And as such, tunnel catheters are designed for short to medium-term access, weeks, months, but sometimes years. Because infection is still a frequent problem, and complication of having catheters are infections, sepsis, and venous stenosis, because this catheter is a foreign body in the vein, and this foreign body provokes an inflammatory reaction in the vein wall. This results scarring and narrowing of the vein, often of the point of occlusion. Arteriovenous fistulas. They are recognized as the preferred access method. To create a fistula, a vascular surgeon joins an artery and vein together to anastomosis. And they are usually created in the non-dominant arm and may be situated on the hand. For example, snapbox fistula, the forearm, usually a radiocephalic fistula called Brescia-Cimino fistula, in which the radial artery is anastomosed to the cephalic vein. Or the elbow, usually a brachiocephalic fistula, where the brachial artery is anastomosed to the cephalic vein. A fistula will take a number of weeks to mature, on average about 6 weeks. During treatment, 2 needles are inserted into the fistula, one to draw blood and the other one to return it to the patient's bloodstream. The advantages of having fistulas are lower infection rates because no foreign material is involved in the formation, higher blood flow rates, which translates to more effective dialysis, and lower incidence of thrombosis. This illustration shows a radiocephalic fistula, and we can see 2 modifications. In the upper diagram, the end of cephalic vein is connected to radial artery, allowing blood to flow directly from the artery into the vein. In the lower diagram, the end of the vein is connected to the end of the artery. This is possible because the hand is also supplied by the ulnar artery. In this slide, you can see different arteriovenous fistulas located on the forearm, the upper arm, and the antecubital fossa. We see a diagram showing how a fistula is cannulated. The needles are inserted into the venous segment of the fistula. This is arterial segment and venous segment of the fistula. One for drawing blood to the dialyzer and the other for returning the cleansed blood to the patient. In this lower picture, we can see a very large pathological arteriovenous fistula. This fistula requires surgical correction. Sometimes it is necessary to use the synthetic grafts instead of arteriovenous fistulas. They are simply artificial vessels connecting an artery to a vein. They are usually made of synthetic material, often PTFE, inserted when the patient's native vasculature does not permit a fistula. They are artificial, they can be infected. Now, some information about another procedure performed using the dialysis machine is isolated ultrafiltration. In this procedure, unlike in hemodialysis, no dialysis fluid is used. The required equipment is the artificial kidney. Because of the high pressure in the blood component, water and substances dissolved in it move across the semi-permeable membrane to the other side. In this way, we can remove excess fluid from the patients, for example, in cases of fluid overload or heart failure, when the patient doesn't respond to diuretics. This procedure is intended for patients who do not require hemodialysis. The next technique is peritoneal dialysis, most often performed by the patients at home. Peritoneal dialysis is a treatment for patients with severe kidney disease. The process uses the patient's peritoneum in the abdomen as a membrane across which fluids and dissolved substances, electrolytes, urea, glucose, albumin, and other small molecules, are exchanged from the blood. There are two methods of peritoneal dialysis. Automated peritoneal dialysis using a device called a cycler, and continuous ambulatory peritoneal dialysis, CAPD. Automated peritoneal dialysis (APD) fluid is introduced through a permanent tube in the abdomen and flushed every night while the patient sleeps. Continuous ambulatory peritoneal dialysis, regular exchanges throughout the day. It has comparable risk to hemodialysis, but is significantly less less costly. In most patients, and very important information that is being the ability to undertake treatment without visiting a medical facility. The primary complication of peritoneal dialysis is infection due to presence of permanent tube in the abdomen. Most people on dialysis with this method are young people that are usually waiting for a kidney transplant. This slide shows that hemodialysis is the method commonly used worldwide, followed by kidney transplantation, while peritoneal dialysis is used for the least frequently. This slide shows that the use of peritoneal dialysis varies across different parts of the world. This method is used most frequently in Asia, while in Europe it accounts for about 15%. About the principles of peritoneal dialysis, these principles are very similar to hemodialysis, but there are some differences. Diffusion with waste products of solids across a semi-permeable membrane. This is own peritoneal membrane with small vessels inside from blood to dialysate fluid. Fluid removal, ultrafiltration is achieved by osmosis in this method because there is glucose in the dialysis solution, and it causes free water and some dissolved solids to move across the membrane into the fluid. The patient usually pours 2 liters of fluid into the peritoneal cavity, and after 6 hours pours out more, for example, 2,400 or 2,500 milliliters. And this method, metabolic acidosis is corrected by adding lactates to the dialysis fluid. The lactate diffuses from the dialysis fluid into the blood, and is metabolized in the liver to bicarbonate, which increases the bicarbonate concentration in the patient's bloodstream. The fluid used in this type of treatment typically contains sodium, but you can see that this sodium is in lower concentration than in patient's blood, only 132 millimole per liter. Chloride, calcium, magnesium, lactate. Remember that we don't use natrium bicarbonate, only lactate. And glucose, there are used different various concentrations of glucose in the fluid. Another technique is hemofiltration. In this technique, the equipment is similar to that we use in hemodialysis, but excess water and metabolic waste products are removed in a different way. This is a continuous technique, usually lasting several days or longer. Unlike hemodialysis, diffusion is not used here. There is no diffusion. There is no dialysis fluid. Solute removal occurs through convective transport. This method is used in intensive care units for very, very ill, critically ill patients. And in this picture, you can see two filters, one for hemodialysis and the second one for hemofiltration. The filter used for hemofiltration has a different construction than in hemodialysis. It has larger pores that only leave proteins and blood cells. Water and the substances dissolved in it very easily pass through the pores to the other side of the membrane and are removed. This is possible thanks to the pressure difference between the inside of the filter and its outer part. In this procedure, we use a huge amount of fluid that we give to the patient, and at the same time we remove it through this filter. So we used a so-called convection transport, with which we remove waste products and excessive water. The patient's blood is directed into a special filter, hemofilter, where the hemofiltration process takes place. This technique requires a large amount of replacement fluid, and as it is necessary to achieve effective convective transport because of the difference in hydrostatic pressure on both sides of the semi-permeable membrane. Water and metabolic waste products easily pass through the pores. The filtered blood then returns to the patients. And you can see replacement fluid. If we, for example, give to the patient 24 liters of replacement fluid during 24 hours, 24 liters, for example, and during the same time collect 26 liters of filtered fluid, we will receive a negative balance sheet of 2 liters. However, this process takes 24 hours, not only 4 hours as during a hemodialysis session. So, what are the indications for hemofiltration? The most common indication is acute kidney failure with fluid overload, hyperkalemia, acidosis, and signs of uremia. When the patient is in a serious critical condition and hemodynamically unstable, for example, after a cardiosurgical operation, in severe heart failure, in sepsis, in shock, deep hypotony. This technique removes very small proteins like myoglobulin, for example, in rhabdomyolysis, especially when the patient often requires large volume fluid administration, including medications and parenteral nutrition. In these cases, hemodialysis would be too aggressive for the patients. It would be impossible to take, for example, 2 liters of fluid during a 4-hour hemodialysis from a hemodynamically unstable patient. Sorry, I'm on duty today. Unfortunately, I have to interrupt my lecture for a moment. Hello? Hello? Proszę zadzwonić do jesieni, żeby to się nagrało. Do jesieni, żeby to ten tam. Dobrze. Dziękuję bardzo. Dziękuję bardzo. Okay, we are starting again. Sorry. Now hemodiafiltration. This is a kind of treatment that combines hemodialysis with hemofiltrations. The filter is like a dialyzer. It consists of 2 compartments. Differs in a high flux and permeable membrane with larger pores. This method is more efficient for larger water-soluble substances. Both diffusion and convection are used in this process. In this method, we use a dialysis fluid and substitute fluid. We use diffusion to remove waste products and convection transport. This method is more efficient than hemodialysis. And what are advantages of hemodiafiltration? Decreased mortality, better phosphate clearance, better beta-2 microglobulin clearance, decreased inflammatory markers, increased EPO responsiveness, better hemodynamic stability during dialysis, use in clearance of light chains, use in treatment of acute and hepatic failure. And the last technique I will be talking today about is plasmapheresis. A synonym of this is therapeutic plasma exchange. There is no diffusion here either. The plasma filter has the largest pores, allowing it to pass not only water and dissolved substances, but also all blood proteins. They only prevent blood cells from passing through the membrane. In place of plasma taken, we must give plasma from a healthy person or human albumin. The main indication for plasmapheresis are substances in the patient's blood responsible for the etiology of the disease. For example, harmful antibodies or immunological complexes. The treatment is not selective. It removes all plasma components, including pathological. There are the largest pores in the membrane of the filter for plasmapheresis, but they are too small for blood cells only. Usually, 5 to 7 plasma exchanges are performed during the whole treatment. Indications for plasmapheresis are thrombotic thrombocytopenic purpura or hemolytic uremic syndrome, myasthenia gravis, Guillain-Barré syndrome, Goodpasture syndrome, vasculitis, ANCA, cryoglobulinemia. We use it in transplantation when there are antibody-mediated rejection and HLA desensitization, focal segment glomerulosclerosis, vasculitis, Henoch-Schönlein, systemic lupus erythematosus in severe manifestations, catastrophic antiphospholipid syndrome, myeloma, and acute renal failure. With acute renal failure and transplantation, we have renal HBO incompatible. So, summary, the treatment methods that I have presented are very helpful in treating the patients. There are many different varieties. There appear constantly new, more perfect. Thank you for your attention. See you in our department.